Okay, I think we are ready to
Is that
go.
right? Okay,
Do you wanna
it says
kick
you're
us
now
off, Susan?
only, yeah, is it right? Is it recording? Okay, I'll start. Hi, everyone. Julia and I are going to take attendance and she did send out an agenda, and Julia's just up front. We are going to switch the order a little bit. So Stephanie is going to be the star of the show tonight. She need to have her do that. But we just flipped the order a little bit. So Julia and I are going to go through a few quick updates from the board, and then we'll switch over to Stephanie to talk about the legislature and all things happening over there, or happened. So I'll just call out the members I see, and then
Yeah, and Susan,
I'll
I
turn it over to
actually
Julia.
I've had
Yeah,
plenty of time to write people's names down
do you
on an
have them
attendance
then?
front,
Great.
so I think
I
I'm
think, yeah, I
set.
think we're there. Okay, awesome. So we can start with our update. Julia's going to pop up slides. I'm going to have Julia run through them. We have a very busy, incredibly busy May, and then super busy summer, but I'm looking at a group of people who are busy all the time, so I am not complaining. Over to you, Julia.
Okay, can you see my slides?
Yeah.
Great. Yeah, so we just wanted to take a few minutes and give everyone an overview of all of the stuff we have coming up this summer, because there is a lot of it. It was actually helpful for Susan and I to do it for our own understanding as well, but there's a lot of opportunities for engagement in the board's processes, so we just wanted to flag those. And yeah, definitely stop me if you have questions, but we organize these by topic, so I will just go through it. So for ACO oversight, if you meticulously follow the board's schedule, which you may or may not, in all your free time, we have been talking about OneCare Vermont's revised budget for FY24, which is a standard process that happens this time of year. We are talking about it one more time next week, but that process is primarily wrapped up. But looking ahead, we're going to be talking about the guidance for ACO oversight for next year. So the OneCare specific guidance we'll be talking about also at next Wednesday's board meeting. And then in June, we'll be talking about the Medicare only guidance. And so those materials, once they're available, will be on the ACO oversight page and then posted under the board's schedule. And I guess I'll also say I didn't send these slides out ahead of time, but they'll be available after, so you don't need to worry about like scribbling down what is up here. We can share them. So that's ACO oversight land. For rate review, the rates are filed with the board in May, which we've just received. In between May and July, we'll be analyzing them. We're having our actuaries look at them, do all of the deep dive there. And then in July is when we have the public rate review hearings, where the board members and actuaries spend the day walking through those materials. And then there's also going to be a specific public hearing for Vermonters to come and give public comment in a verbal capacity, whereas we're always accepting written public comment anytime. And then the decisions are issued in August. Everything rate review related can be found on the rate review page, which is linked here. Hospital budgets, which are a little farther off. But in July, we received the budgets from the hospitals. We have a very, very busy August schedule of having public hearings during the day, sort of all day hearings, multiple days a week during the week to go through the budgets. And then those decisions are in September. The guidance for hospital budgets for next year was something we just did earlier this spring. So that's what is currently up on this FY25 hospital budget page. But once we receive the budgets themselves, they'll also be posted there. For certificate of need, we wanted to flag that we have a public hearing on Monday for UVMMC's outpatient surgery center CON request. And during that hearing, similar to the other processes, they'll be walking through the materials that are in the record, which are also all linked on this page. So you can find that there. And then,
That starts at 9 a.m., Julia. Just,
oh,
I always
yes.
remind people because it's early in the day, but it'll be recorded too.
Yeah, and all of our meetings, I think you all know this, including our PCAG meetings, get posted on the board's YouTube page, which is linked on our main board meeting page. So you can go back and watch anything you'd like at whatever speed you would like. And then for the ahead model, as you know, we have been talking about it at board meetings and also with groups like PCAG multiple times over the last few months. The board has started holding monthly updates on this topic. And I wanted to flag earlier today, we had the Vermont provider perspective on global budgets and the ahead model that, like the other meetings, will be posted on our YouTube page. And in a second, I'll let Susan give any reflections that she maybe wants to highlight. But then next week, we're having another panel with more of a national perspective on value-based care. And again, all of those materials are posted. But Susan, I'll maybe pass it to you if you want to recap today.
Yeah, no, it was a really robust discussion, really helpful. And I know you all have participated here on different presentations, but I would just put the request out at the end of the meeting. Chair Foster asked for any of the providers and people doing healthcare in the state of Vermont if they could share their perspective, number one, but also there's a real, like kind of looking at the numbers of like how much would we save in a model versus how much it costs to do a model. Sorry, my dog is barking. We are going to continue to hear from providers and panels, and I think any experiences you have on the front line, I think we would be interested in hearing. And sometimes it just depends on, sometimes when you're right out on the front line, you really don't see it. But I think that what we heard from Jessa Barnard and other primary care providers is just the administrative burden and being very thoughtful of what we're doing as it relates to administrative burden. So that's all I'll say. If you get a chance, you can watch the presentation. It was really interesting. You can, as Julia said, you can speed it up too. That's all. Thanks, Julia.
Yeah. And then I know this is a very busy slide because we keep adding boxes to it, but I also wanted to highlight where we are about to be on the community engagement work. As you remember, in the fall, we had community meetings, both focused for community members and providers in each HSA. So there was 14 meetings times 2 for those different groups in the fall. And that was to just sort of talk about everything, anything that people wanted to share about what could be done to improve healthcare in the state. There's a presentation linked here that Bruce Hammery, our consultant who's facilitating those meetings, gave to the board in January about the themes from those first round meetings. Since then, there has been a bunch of data analysis work, both to pull out those themes from the qualitative discussion meetings that we had, and then also to look at other forms of data and sort of like put all of that together to work on developing recommendations. We're going to be having a second round of community meetings this summer in July. Those will be in person throughout the state, so physically throughout the state. We aren't quite at the point of publishing the schedule because we're working on reserving venues for each of those meetings, but the request that will be coming your way once we have it is help promoting these meetings to your networks, whether that's your fellow healthcare provider colleagues or patients or both. We're still working on developing what all the materials that we'll have to help promote these meetings, but last time around we had done a like flyer or poster type thing that you could print out and put up somewhere. So I'm thinking we'll do something like that again. Happy to talk with folks if they have ideas about other formats that would be helpful for you to disseminate this information, but we'll be posting the schedule on the website that's linked down at the bottom, and we'll send you an email package with more information once we're a little closer. But I wanted to flag that will be coming, and we would love your help encouraging people to come to these meetings where they'll get to hear about the recommendations and have discussions about which things seem like they might work better for the local healthcare areas. So I know that was really vague because I don't have something to hand you yet, but soon you'll be getting an email. So we wanted to flag it. And I think that is my last slide. So anything, Susan, that you wanted to add, or any questions from any PCAG members? Like I said, we can send the slides out. I know that was a lot. We just wanted to sort of package everything that's upcoming, since the summer is a very busy time for the board and a time where people's schedules tend to get busy anyway, because we have more daylight and time to do things. Any questions from PCAG members about that before we hand it to Stephanie to talk about the legislative session? Okay, Stephanie, it looks like the floor is yours, and thank you for taking the time to come do a walkthrough. I know we're only a week, not even a week. We are in the week after session wrapped up, but
Yeah, thank you. And I will admit that some of these bills were a little sparse, and I don't have links to them because I think Legislative Council just went home after Tuesday and they're not back, because there's no current versions of bills that have passed and there's no real updates. So I'm giving you sort of a minute by minute end of session flurry of activity and where we landed, but there may not be many links in my presentation. So I'll just pull up a few slides, but I really do want to have this be interactive, interrupt me, ask questions, and then we can go from there. So let's see, do I have sharing? Yep.
you should.
All
Okay,
right.
great.
You can see that? All right, perfect. Okay. So just a reminder that I'm Stephanie Winters, and I'm the Deputy Director of the Vermont Medical Society, as well as the Executive Director of the American Academy of Pediatrics Vermont chapter and the Vermont Academy of Family Physicians. So really, most of these bills are done in tandem with the three groups working together collaboratively. And that's easy to do since I work for all three groups. So it's a nice marriage of people. All right. So the first bill I wanted to talk about, and it looks like it's just us chickens on this call tonight. So I maybe can be give some inside information, but the H766, I just sent out.
And Stephanie, I will just flag for
it's
you,
recorded.
just so you know. It's
Yeah.
recorded.
Yeah, I
It'll
was
go
just
on our
gonna
YouTube.
say that. Thanks,
Okay,
Julia.
just making
No, I
sure
knew
you know.
that. It's
Okay.
not really,
It's just us
not
here.
really
Yeah.
inside. Not really inside. I'll keep my comments to myself. So H766, we sent out an alert through the VMS yesterday, and then I sent an alert out today to other specialty societies that I work with on this bill. It arrived at the governor's desk yesterday, so that means he has 5 days, which is Monday, because we don't count Sundays. So he has 5 days to make a decision. So this bill had a lot of changes throughout the session. It started as I think the biggest change was it started as an alignment with Medicaid for prior authorization. So it was really more of a simplification of what prior authorizations were required throughout insurers. But it got to the Senate, and it was so interesting. They were almost ready to do it. And then Senator Kitchell came in and said, we thought she was, we thought that there was going to be a wrench thrown into it. And she really said, primary care really needs this. So why don't we focus on primary care and do studies? And then I think it was Senator Hardy and Senator Lyons were like, well, why don't we just remove prior auth from primary care? And that came from Paul, that came from Representative Black, who was like, let's just do this. If they really want to affect primary care, let's throw this in. And so Senator Kitchell agreed to it, and it just like rolled from there. Obviously, insurers were not thrilled with this change, but we really thought that this was a great compromise. It obviously does not include medications, but neither did previous iterations of the bill. So this would prohibit insurers from applying any prior authorization for primary care, except for prescriptions and out of network. But prescriptions are affected in different parts of the bill. It would also require insurers to cover, without prior authorization, a asthma controller medication from each class and each mode of administration. So this is born out of the changing of or discontinuation of Flovent, and then not having other HFA inhalers available for children, and then Asthmanex going on shortage, and the fact that none of this was being covered, and those taking care of children were really struggling, as for the children not being able to get their inhalers. So we got this language in to make sure that there was without a prior authorization inhalers available and covered without prior authorization. It would also reduce the time frame for health plans to respond to prior authorizations, so 24 hours for urgent requests. And then it would require authorization for treatments and medications to last for at least a year, and require for those on ongoing treatments a 5-year prior authorization, which would affect medications. So I think that is really, while the prohibiting or the not requiring prior authorization in primary care doesn't include prescriptions, this part really has to do with prescriptions and will help with that. It also allows exceptions for step therapy. So if you have patients on a medication or a treatment and they're stable on it and it is working, this bill would allow an exception to be able to not have to go through step therapy requirements for that patient and that treatment. And then finally, it would help with the claims edits issue with the prepayment for the coding edit standards. This started last January. We mainly heard about modifier 25 and 59, but there was hundreds of different code edits. So this would prohibit prepayment claims and would include those used with modifier 25 and 59. So as I said, this was delivered to the governor yesterday. He will have till Monday. In his press conference today, he did talk about, he had some concerns about cost, but that he had been hearing from practitioners and hospitals, and that there is a benefit to patients and to the healthcare system. And so we just need to keep telling him stories and letting him know that this could really benefit everyone. So just included some links, and I'll send these to Julia so you can send them out to the PCAG members. Tim, go ahead.
Stephanie, do you have any sense of what, in terms of the step therapy and proving or showing that somebody is stable? I mean, I'm just imagining, it's another prior auth workaround called something else to have to provide documentation that we've tried this is stable. We don't need to change any sense at all what that's going to do.
I don't have a sense of what that exactly looks like. I think we'll have to keep a close tab on that. So, I mean, I can envision what I would like it to look like, but that doesn't mean that's what it's going to look like. But hopefully, if it does not go the way that we want it to, and it does become a workaround, then we'll have to go back and make sure that the legislature knows that the intent did not occur. Elliot?
Oh, yeah, I just had a question. So this is specifically for primary care. How would it be if somebody who was, let's say, a GYN was sort of acting as somebody's primary care, because some people continue to stay with them?
Yeah, you have to be credentialed as a primary care. So an OBGYN would probably not fit under this. And this whole bill is not just primary care. So it's just the first part about not having prior auth in primary care. The other pieces, step therapy, reauthorization, and those things are for all specialties.
Okay, thank you.
Yep. Where's the number 3? Wait, Michelle, okay, the numbers all changed. So I think Michelle was first.
Michelle.
Yeah.
I just want to clarify. I had heard when I was in Montpelier this past week and spoke with the governor about this bill, but I had also heard that it was, as you indicated on here, only for insurances purchased off the exchange. So I just wanted to clarify that any employer-sponsored insurance is not going to be a part of this, correct?
That is correct. We don't have any ability to tell those insurance plans or Medicare what to do. So yes, that is correct.
Thank you.
Yep. Hey, Paul. Oh,
yes,
Faye.
thank you, Stephanie.
Hold on. Phase 1 now. Hold on. I'm trying to do the numbers right. Faye.
Thanks. My camera is not working for some reason, but so there was this article this morning in Digger that with the insurance companies proposing their rate increases for the upcoming year, they were hefty, up to 19%, and specifically blaming H76 for some of that cost. And I would love to have data to be able to effectively argue that point that it doesn't have to do with H76. And I don't know if you have anything to add. Anyone has anything to add on that? I think these some limitations on prior auths have been done in other states, and I think it hasn't caused overwhelming changes in cost. I think we're doing that without, we're doing that anyway, but I'd love to know what people think about that.
Yeah, I'll just say we do have an FAQ specifically about the cost and have sent that to the governor's office. We would have been the only state to align with Medicaid, but I don't think we're the only state to. I mean, there are other states who've done step therapy. There are other states who've done the coding standards. And I don't know that we're the only state about basically doing away with primary care prior auth. But first of all, I would like to say the governor did in his press conference today, and I won't get the quote exactly right, but he did say, "I wish there were real numbers." So to me, that means he's not necessarily believing all of the high numbers that come out, and that he would like to get some different numbers, and perhaps he could ask DFR or somebody to do those numbers without vetoing the bill. So I have, that makes me optimistic. But again, he needs to keep hearing how, examples of what happens in practice and why this would affect cost in a positive way. And the talking points are included here. And I'll email these out right after the presentation to make sure you guys all have them. Paul.
Thank you. Yeah, sort of comments and questions on all those topics. The One question that maybe we don't really know is the question of whether there may be a veto-proof majority and allowing this to pass anyway. So that's hopeful if it is. I heard that it's quite possible that there is. Number two, on the costs, is that something that can be distributed so that we can see what the payers have submitted? Because I really, one of the things they always leave out is, they indicate what's been denied, but they don't then subtract what's been approved and the difference in cost, only the total cost of what was denied. So it's the difference that matters, not what was denied initially. And then also the payers always need to be asked, well, how much are you paying the docs? Well, that's not really the question because they're not paying us anything. The real question is, well, what is your estimate for the amount of time and resources for the doctors and the doctors' office staff to administer this program for you for free? What is your estimate? You have to put an estimate on that because it's a cost to the system that practitioners are providing you, the insurers, for free, and it's hurting our system. So ideally, the governor or other people have that question to ask the insurers back when they submit these, sort of phony cost estimates. And then just to clarify I don't think it's just the exchange, because for instance, we're a small office that buys MVP for our insurers. They're exchange equivalent plans, but they're not purchased off the exchange, and they would apply too. We're not self-insured, so I don't think it's just direct purchase exchange plans. It's all plans that are from the exchange or equivalent to those sold. Maybe you can clarify that.
Yeah, it is plans on the exchange. So for instance, VMS buys off the exchange, but we aren't self-insured. So it would be exchange plans, but not self-insured or ERISA plans or Medicare plans.
Right, but ours aren't bought off the exchange.
I think it might, and we can help clarify too. This is Susan. I think it's like, because MVP and Blue Cross Blue Shield have large group plans that come through, and they're not on the exchange. And I'm going to get all my terminology wrong, but there are other plans that are regulated through the state that are not through the exchange. So I can try to help you with that, Stephanie, and we're going to want to understand that too at the board. So we'll follow up.
Yeah, so this bill will apply to state regulated commercial insurance plans in Vermont.
So it is
MVP, Blue Cross Blue Shield Vermont, and Cigna plans sold on the exchange.
Yep.
So that's okay. So, but that's misleading, isn't it? Because it will apply to, for instance, in other words, we're not self-insured. We provide the equivalent of a silver plan, but it's bought directly through the payer. I would think that those would apply, even though they're not. Nobody goes on to the exchange and buys those plans. Yes?
I will need to think about that, but I think yes, because those plans are regulated in Vermont.
Exactly.
By Vermont.
But they're not purchased off the exchange. So right.
Right. Yeah, I will double check about that, Paul, but my inclination would be to say yes on that, because your plan is regulated under the state of Vermont. It's not a self-insured. So I will get back to you though. That's a good question. Now you're going to test my memory. Going back to the first question, veto-proof majority. We had a veto-proof majority with the vote. So in the original House bill, which did not include the removal of the prior auth for primary care, remember that was the alignment, it was 137-0. So, but they just did a voice vote on the concurring with the Senate bill. So, there will probably be some more no's, but I think there would be enough. We'd need 100 votes, and I think we would have that. The Senate, there were only I think it was a voice vote, but I listened and there were 2 no votes on that in the 30s. And so we would need 20 votes. So, but as all of this comes out and they have more time to think, and if the governor vetoes it, you're probably going to lose a lot of the Republican votes. And so, you could have a little bit of switching of votes, possibly in the Senate and the House, but I feel like we could have a strong veto-proof majority. If we don't, there is always the option, this will be a special session, so they could do a whole nother bill. They could just introduce a whole nother bill. And hopefully it would have to be something that they think that the governor would sign, obviously. And so we'd have to look, it could be a delay in the implementation period, but I don't want to go there right now. I'm going to think positively. Number 1, that the governor is going to sign it, or number 2, that we have a veto-proof majority. The second question, remind me, Paul, what was the second question? Because there's 3 questions. We answered the third.
I think the
second?
other one was more of a comment that had to do with the cost accounting by the
yes.
insurers and
yeah. But I did want to say that there are studies included in the bill to look at the impacts and the costs by both the insurers and the hospital and health system. And so those are already included in the bill. So we've actually reminded the governor that, well, you may want those, but we've already asked for them. I'm not sure a DFR report would be, because they're talking about an actual aerial report, and we have said that won't include the intricate details of what costs money and what saves money, and the cost to the healthcare system and the cost to offices. And there's just so much more to look at than X minus Z equals. So we've made it really clear that it would have to be a really in-depth study that would cost quite a bit of money to look at, and that nobody's really done that before, which maybe that would be a good thing. But let's put this into place, and if we need to look at it, let's do that. But I agree with you, and we've thought of that as well. Faye. Faye, did you have a question? Oh, there you are. Okay. Rob.
Yeah, just to expand on what Paul said a little bit about avoidable costs. We've always mentioned the costs that come about from people getting sent to the emergency room for their head CT or whatever that they couldn't get prior approval for in a timely manner, and people that just end up in the ER because they didn't get adequate care in a reasonable length of time. Again, that's something that I've never heard the insurance companies figure into their calculations as far as cost. And then another question, a number of the Medicare Advantage plans are administered by Blue Cross and MVP. I assume those wouldn't be covered by this bill, even though they're managed by the in-state regulated health insurers.
But they're not regulated in Vermont. So
I mean, even though those companies are regulated in Vermont.
Yeah, right.
Okay.
Because Blue Cross offers self-insured plans and to the state, and the company's regulated in Vermont, but those plans aren't.
Yeah. Okay. Too bad.
Yep. Okay. Are we ready to move to the next bill? H721 was the beginnings of what I think legislators were hopeful would be like a new health reform marvel, Medicaid for all. So it started as a Medicaid expansion bill. I think the idea was to expand Medicaid to the federal poverty limit, so there would be more people eligible for Medicaid. It would have increased payment to primary care, but not specialty. But the increase, we talked to legislators about how the increase wasn't adequate, because if you pull people off from commercial insurance and only offer 125% of Medicare, that's a cut for primary care. It would have been a pretty big cut for specialty as well, because it wouldn't have increased their payment, but they would have been seeing more patients at the Medicaid level, and they are around 81 to 83%. So they are well below 100%. And so we talked to them. They decided to make it into a study, to study what this would look like, study what rates needed to be, study how to do it all at the same time. But then it got over to the Senate, and they decided that there wasn't enough money. They were talking about whether to include just adults ages 19 and 20 and pregnant individuals. But in the end, the bill did not pass. But there was a piece for the Medicaid Preferred Savings Program, or the Medicaid Savings Program, which helps to pay out-of-pocket costs for Medicare for low-income individuals. That did stay in the budget, so there is funding for that, but the actual bill did not pass this year. And I should say, because this is the second year of a biennium, these bills are now dead. So they will all everything will have to be reintroduced after the election year. H861 is the audio-only telehealth parity bill, and this bill passed and was signed by the governor. So this bill removes a sunset in state law requiring paying for audiovisual telehealth services. So that was, during the pandemic, it was put at parity, and then after that, they're like, well, we'll have it at parity, but we're going to sunset it. Then DFR put into place that it could be 75%. And so many insurers picked that 75% to pay, but now with this law, it will now go into effect that it will be 100%. So audio only calls are now covered at 100% of telehealth and in-person calls or visits, sorry. S18 was a flavored tobacco bill. I'm sure a lot of your patients are struggling with vaping and flavored tobacco. Unfortunately, this bill was vetoed by the governor. It made it through both houses. It did not have a veto-proof majority, so there was some talk of trying to put this language on other bills, but they ran out of steam at the end. I have heard that this will be a bill next year, that it will exclude menthol, and so hopefully we'll be able to have the governor's support on that next year. H612 is a cannabis, is the perennial cannabis bill, because every year there is a bill about cannabis. And so this year there was one, in the beginning, it would have removed the potency cap for retail cannabis. And we were able to remove that. There were also concerns about the medical endorsement, the medical program, conditions on the list for medical cannabis. And at the end, and I'm saying this is like the 10th of May, this is the last day. They were there till 2 a.m. Right before the gavel, I think they probably figured this one out, that they were feeling too rushed. There were too many provisions. And so they put most of them into studies and rulemaking, which is good. This is so they will have to look at it more and bring some of these things back to the legislature. I say it's good, but that means there will be another cannabis bill next year, but there would probably be one anyway. H469 is really a bill that allows remote and electronic execution of advanced directives in many fashions. So it means you can witness an advanced directive through interactive means. You can explain an advance directive to an individual who's a resident of a nursing home or a care facility. And then the Ulysses Clause, which allows the authorization or withholding of future care. It allows you, the clinician, to explain the risks and benefits virtually or over telemedicine. So that bill passed both bodies, and the governor signed that as well. There were two bills for prevention screenings. The first was H741, which is about colorectal screening. And our statute in Vermont had an age, so it had 50. And as hopefully we all know, that has been reduced to 45 now. And we thought, well, it would make more sense to follow screening guidelines instead of putting an age in our statute. So this would provide colorectal cancer screenings at no cost to patients based on USPSTF guidelines. And similarly, H621 it will expand mammography coverage to include other medically necessary breast imaging services such as MRI, ultrasound, upon the recommendation of healthcare providers at zero cost as well. So this means, a lot of patients who have dense breasts and mammography isn't as accurate, you will be able to, after January 1st, have them go and get a breast MRI or an ultrasound at zero cost. So those were both signed by the governor and will be law as of January 1st, 2025 and 2026. There was a bill that passed S109. This started as a full Medicaid coverage for doula services. The American College of Obstetricians and Gynecologists support this bill and support doulas as an important part of the birthing team. There was a lot of questions from both insurers, from Medicaid, from OPR, the Office of Professional Regulation, who licenses a number of specialties, as to how this would work, how we would put this into play. And so this really became a study, and a report will come back from DVA, the Department of Vermont Health Access, to talk about the estimated costs of providing Medicaid reimbursement, and then how they're certified and what that looks like in terms of licensing. This bill was signed by the governor as well. S164 was a bill actually put forward by the Vermont Medical Society. This is coverage for obesity treatment. So that includes medication, lifestyle interventions, surgery, if that's warranted. It received hearings in the Senate Finance Committee. DVA came forward and came in with testimony that this would cost $65 million. We have costs that are closer to $1 to $2 million a year. And that's just cost of the medication, you not taking into account the savings from the prevention of disease. And so that basically shut down conversation in the legislature. We tried a number of different ways to get a report or a study, and we were unsuccessful, but we are continuing to work with DVA, who's been willing to come to the table and has a obesity treatment work group. And we're hoping to get a cost analysis before the next session, so we can talk about that. Eileen?
Without going into too much detail, that is a huge delta between 1.6 million and 75 million.
There is.
Where was that kind of coming from? There must be huge differences in the context of how they were calculating or how they were looking at it.
Yeah, I mean, it's so interesting. I think they were taking every patient that's would be considered obese perhaps or overweight and like calculating it by their lifetime. I'm not sure how they came up with that number exactly. They couldn't really explain it in a great fashion, but it's a lot. and we, you know, we're a small state. I feel like even if every person, you know, took this medication, I'm not sure we could get to $65 million, but in a year. But yes, I agree. That's a huge difference. Anyway, so that bill did not advance. I think we will be back at the table next year with hopefully more information. H72 is the Overdose Prevention Centers bill. This is a bill that got a lot of media attention. Some of it because of you know, where funding was going to come from, and the governor is not really in support of this this measure, but this would direct VDH to create guidelines and direct funding for the creation of one overdose prevention center. Originally, it was two, and they put it down to one. It would be located in Burlington, and it will be funded out of the opioid abatement special fund. So the funding that we got as a state for the opioid settlement. This just goes on to define the roles of the overdose prevention center, and it also, and this was important for us, we let the legislators know that there needs to be immunity protections in this, and so it does include immunity protections for, and there's a long list of people, including you know, staff members, operators, healthcare professionals, property owners, and state or municipal employees, you know, acting within their role. So this has passed. It's awaiting the governor's decision. I do expect him to veto this, but I do think it has a veto-proof majority. So we will wait and see. You know, when I say it's awaiting the governor's decision, all these bills have, you know, they've all passed, or well, if they failed, they're not going to him. But so all these bills have passed. The Legislative Council has to clean them up, make them pretty, and then deliver them to the governor. They don't do it all at the same time because he would be inundated. So it takes some time for some of these bills to get to his desk. But once they get to his desk, he then has the 5 days to sign or decide or let it go into law without his signature. But I do expect, he has made comments about not supporting this one. S302 is a public health outreach program regarding dementia risk. This has been a few years in the making, and born out of the belief from some legislators that both the public and healthcare professionals don't have enough education and knowledge about dementia risk. And so they really wanted to call on the Department of Health, Dale, the Department of Mental Health, to include as part of their current or existing public health outreach programs to talk about early detection and timely diagnosis of Alzheimer's and other types of dementia, validated assessment tools, benefit of Medicare annual wellness visits, significance of family, and necessity for language access services, and then also public education plans. The Department of Health already does some of this, and so I don't know that we'll see much difference. I think all of these organizations are already doing some of these things, and so you probably won't see anything different. We've always been watching for mandatory CME, which we would oppose because we think that having specific things for everybody is not really an ideal way to educate. And so we've been watching for that one, but it did not come up and it's not included in this bill. H870 is the Office of Professional Regulation Housekeeping Bill. So as I mentioned, OPR, or the Office of Professional Regulation, regulates, I'm not sure, 92 professions, 140, a lot of professions, from dentists and nurses and osteopaths to landscape architects to tattooists to plumbers. I think like it's this wide variety of people that they license. And so every year they have a bill and it includes changes to multiple professions. This year, it was pretty short and not much in there, but one thing that came to us from the naturopaths was a request, and this has been a perennial request that we've sort of said the Department of Health makes rules on this, and we follow the Department of Health on naturopaths signing death certificates. As you may know, I think naturopaths became primary care practitioners in, I want to say 2009. But when Craig Jones was the head of Blueprint and Harry Chen was our health commissioner, and they decided that naturopaths should be included in the Blueprint and therefore were considered primary care providers. And so they came to us again. They wanted to meet collaboratively, or the legislature asked them to meet with us. And we all sat down with the health department, Patient Choices, the Vermont Ethics Network, and naturopaths to talk about the fact that they wanted to be able to sign death certificates because they see patients from the span of life, and also birth certificates, which apparently they've already been doing, and the health department accepts that, but in statute, it does not show that. And so we discussed this, but they also wanted to participate in end of life Act 39 and write DNR and COLST orders. We hadn't looked much into this. Patient Choices didn't have real information about this. The Ethics Network hadn't looked into this. VMS also represents physicians' assistants, and I think they and nurse practitioners, APRNs, are not included in this. And so it's like we need to look more into this. There was also a question about hospice and Medicare coverage and Medicaid coverage, and so it seemed like there was a lot of information that we needed to gather. So the agreement was to put in to statute the death and birth certificates, and then form an advisory group for which the VMS is a named group member to come back and look at the Act 39 and the DNR and COLST orders. So that also passed and is awaiting delivery to the governor. And then there's just 3 child-specific legislative efforts. The first is 289, S289, which I'm really excited about. The only problem is it's on this controversial data privacy bill that I'm not so excited about. And the governor could veto, so that would be a real bummer. But S289 is really a bill to mandate that online platforms make it safe for products that are reasonably likely to be accessed by children under 18. So it would institute privacy by design and default, be designed with kids' best interests. And so the continuous scrolling and the people who, the geofencing where they track, who the people who look up young children online and then they suggest them as friends. And there's just all kinds of malicious and pretty disturbing things that happen on these platforms. And so it would help with a lot of those. And it would really be, I think of it as the social media and online prevention model, instead of limit screen time and, don't give your kid a phone until they're 12. This is more like, okay, let's fix this from the ground up. So hopefully, even if the bill's vetoed, hopefully this piece can live in some form or fashion. S187 is a bill that seems so interesting to me that this has not been allowed, but student application of sunscreen in schools. So with written permission from their parents, children can now bring sunscreen to school and apply it. So that was passed and the governor signed it. And then the miscellaneous DMV bill that I never thought I would necessarily have to follow. I was hoping to add primary enforcement of seatbelts on this as well, but that would be probably a veto waiting to happen. But this updates the child safety seat laws to align with AAP guidelines. So rear facing until 2, booster seat after 8, 5-point harness, front facing till 5, back seat till 13. It doesn't mandate that because everybody has trucks without a back seat. So we had to say recommended, but so I'm happy about that. I think it will be signed by the governor, but it's waiting to be delivered to his desk. And that's it. So any questions, let me know, or we can have discussions now, and I will send these slides with the links to Julia as well.
While people think about questions, I'll just jump in and say thank you because that was a great overview. And again, so much of this happened in the last few days or the end of last week. So thank you for putting all this together on such short notice.
Yeah. I did such a good job. There's no questions. And we had questions in between. So we were efficient. Right.
I'm not used to
Contact
this
the
group being
governor.
so quiet. I keep waiting.
Contact the governor. That's all we have to do.
Okay. Well, I don't see questions from PCAG members. I see a couple people who aren't PCAG members, and we do, because this is part of our public meeting process, we also do public comment. So if any of the non-PCAG members had any comments they wanted to make, you can raise your hand or say something. Or everyone's like, it's 6:30 and I'm ready to be out of here, which would also be fun. Okay. Trying to leave enough quiet time that I don't cut anyone off. But yeah, like we said, I will get the slides from Stephanie and also my slides and get them packaged and posted and sent out to everyone over email. And then, like I mentioned, as it relates to some of the board's other work, we will have, once we have the schedule for those community meetings in July, the meetings are in July, but we'll have the schedule hopefully in the next couple weeks as we lock in locations. So we'll be sharing that out with you so that you can hopefully put it on your calendars to come to the meetings, but also share them with your colleagues and patients and friends and communities and anyone else. So you can keep an eye out for that. But yeah, thank you again to Stephanie. Thank you again to PCAG members for taking time out of your busy schedules and your evenings to be on this call. So I hope everyone has a great rest of their night and we will wrap up the meeting there. Thank you.
Thank you.